James. I'm a cardiac physiologist, and now I'm really glad to report, I feel like I belong here by saying I'm a registered cardiac scientist as well. I'm also an NIHR clinical doctoral research fellow, so I'm a little bit of background. I started as a trainee physiologist at the London Chest before we merged with Barts, came here in 2015 and have progressed sort of through the ranks to have an education and a research role now. And I'm very fortunate to have, be able to do a split role with a part-time PhD balanced with the education and research role, trying to sort of encourage other people to follow the same path that I'm taking at Barts. And we've got some, cardiac science SDPs in the audience here, and that's part of that process. They're part of that plan. So really, yeah, we work with a fantastic team, and I know Hannah, my right hand SDP trainer, is in the audience as well, and couldn't do it without her. So hopefully this will move forward. Try the other one. If in doubt, try the other one. There we go. So I'm here to talk about the physiological sciences, and I'm going to start with an admission that, obviously I'm very cardiac centric, and I understand that there is over 50 disciplines of healthcare science, and they're broken into 4 domains, and one of those being physiological sciences. But this was a learning point for me writing this talk, and I hope today is as useful for you as it has been for me, is that the physiological sciences are more than just cardiac science, more than the ones I know. I know vascular and respiratory very well, and some chaps in pathology, because they take our SDPs, we take theirs, and we are very fortunate to have that sort of good relationship with them, and that's how we've sort of come to know them quite well. Some of the other disciplines are not quite so well known to me, so actually writing this brief talk was very useful in that respect. So we're going to talk about briefly what the physiological sciences are, and if anyone's in the audience from those physiological sciences and needs to correct me, do shout out at any time. And we'll also touch on what pathways in the NHS we commonly touch and contribute to. And I think one of the best ways of explaining that will be to just go through a few case studies of example patients. So I just wanted to go back to the healthcare science level, and I'm glad that myself and Art are singing off the same hymn sheet, where this is a stat. If you do any Google search and put healthcare scientist in, this is one of the first stats that come up. And it's as Art said, it's very impressive. 80% of all clinical decisions in the NHS. I mean, in cardiac physiology, certainly, or cardiac science, everywhere in this building now, they're almost on all floors of certainly the first 4. In fact, up to the wards on floor 6, there will be a cardiac scientist beavering away with either a mobile echo machine, or doing an ECG on someone, or doing chest compressions in the cath lab, or fiddling with someone's pacemaker on the 2nd floor. We really are everywhere, and anyone, certainly cardiac patients who comes in, I can imagine that figure might be slightly higher. So what are the physiological sciences? Let's broaden it out a bit. So these, like I said in the lead up to this talk, I did my Google search, and this first website, healthcareers.nhs.uk, I don't know how long that's been active, but certainly when I was coming towards cardiac physiology, I had really very little knowledge of the other careers in the NHS other than nursing and medicine, and I think that's a similar story. Certainly a lot of my sports science graduate colleagues, because that's a very similar story. You do sports science, you don't know what to do afterwards, you end up in cardiac science and cardiac physiology. If this sort of information had been out there then, I think I might have come to it a little bit quicker. And these really are, and Joe, you talked about it, these guys are really trying to put the information out there succinctly, nice, clearly demonstrated on a website, and I found that really, really useful. It's clear, it's concise, there's links to further information, there's links to, if you're interested in this, if this floats your boat, well, think about these careers. And I thought these 3 certainly have all singing off the same hymn sheet, and very, very useful tools. So like I said, the physiological sciences, when you go onto the Health Careers website, click on physiological sciences in the bottom right, and it'll take you through to the sort of 10 or 11 careers. So the first one is, I'm just going to very briefly touch on them. I won't bore the experts, because you know what these are, but audiology, so looking at the hearing and balance and associated disorders. Cardiac sciences I've already mentioned, and we'll talk a little bit about those later. Clinical perfusion science, so essentially the scientist who's in the operating theatre, especially the cardiac operating theatre, looking after the machines that are perfusing the vital organs of the patient while their heart is not doing so. So their heart's stopped for cardiac surgery or whatever it is. These guys are keeping those organs perfused. Critical care science, so these are, my understanding is that these are the guys on ICU, on critical care, on HDU, making sure that the machines that are vital for that patient's survival are just keeping ticking over. Not the medical, not the chaps who are repairing them, but actually the day-to-day, like keeping them in working order, putting those drugs in, keeping that patient alive. So absolutely vital role. Looking after really, really ill people. GI physiology, so this goes from the entire GI tract, and I believe it includes the liver and the pancreas as well. So any sort of physiological assessment of that system. Neurophysiology, where's Richard? There he is. So central and peripheral nervous system, am I right? Perfect. So up on the second floor of the Royal London is their department. Ophthalmic and vision science, obviously anything to do with vision and associated disorders. Up on the fourth floor here, and second floor at the Royal London, we've got respiratory physiology and sleep services. And again, we know those chaps very well because of our collaborations with SDPs. So these guys are doing, cardiopulmonary exercise testing, sleep studies, spirometry, lung function, full lung function tests, etc. So urodynamic science, anything to do with the urinary system and again, associated disorders. And finally, last but not least, vascular science. The guys just through the wall here, Kate, Amy, and others who you've already seen some details on. So that really encapsulates the physiological sciences. So that was, if you asked me to rattle them off without looking at the screen, I could probably do it now, but before this talk, it was useful doing this. So these are our wide world just in physiological sciences. So what pathways do we contribute to? And I think the physiological sciences, let's look at. So I think really the easy answer would be, I'd be pretty game to say all of them. There's not one, so let's, cardiac obviously from what I've already mentioned. Cancer, we've got one of the largest cardiothoracic and cancer centres in Europe here. We're in it right now. There'll be healthcare scientists and physiological scientists on the upper floors as well as the ones I've already mentioned. The renal department, we've got a massive renal centre at the Royal London. The guys the healthcare scientists looking after the, what am I trying to say? Thank you, yeah. So looking after those devices, keeping those patients effectively alive. Stroke, we've got a massive stroke unit, so patients assessed for sort of cardiac arrhythmia or looking at non-cardiac reasons for stroke, looking for obviously pathology, blood tests, blood clotting disorders, healthcare scientists involved. The trauma centre again, I'm not meaning to focus so heavily on the Royal London, but it's just such a hot spot of different pathways with A&E also. Healthcare of the elderly again, so assessment of valvular disease or arrhythmia in that population. And we've also got some community-based healthcare scientists and physiological scientists. So speaking from experience, some of our team go out and do an outreach clinic for echocardiography for patients who can't make it. So it's all very well sitting in our large tertiary centre, but a lot of patients, the way we're looking or moving towards is sort of early identification of disease before that patient presents at A&E in a real state. Getting out into the community, early identification of arrhythmias, early identification of valve disease. Let's not wait till they have a stroke. Let's catch them in the community, and we're all part of that in different ways. So I wanted to put I don't know if this is probably a bit old for most of the people, but many Monty Python fans, they're always complaining, what do the Romans ever do for us? So I just changed that with physiological sciences. So, and the answer is quite a lot. We've done, due to aforementioned areas, we're involved in, everything, every little pathway you can think of. So I thought I'd just quickly go through some patient examples. So patient A, imagine patient A. So they've been seen by their GP. They're complaining of a history of breathlessness. The GP orders some blood tests and a chest X-ray. and let's imagine that chest X-ray takes a little while to get the results back. So the blood test may well have been looked at by depending on their setup, by someone in life sciences, and they get a respiratory referral at the same time. So they come to Barts and they see their respiratory clinician, and they get referred up to lung function. Of course, one of our respiratory colleagues will do a lung function test and report that. They also have a chest CT based on the chest X-ray coming back a bit suspicious. Lung function tests are back at the same time, showing some reduced lung function, some obstructive disease for unknown reasons. A chest CT, they go on and have that assessment, and they're diagnosed with lung cancer off the basis of that. So they then go on to have partial lung resection, having surgery, and all the aftercare that requires on the unit. So the critical care scientists looking after those machines, keeping the patient alive. They then have initiation of chemotherapy. So they obviously don't want they got the tumour, they don't want the tumour coming back, so they have chemotherapy. And a hot topic has been for several years now is the link between cardio-oncology. So obviously, if you don't prescribe the chemotherapy, you're going to die anyway. But if you initiate chemotherapy without keeping a track of the cardiac function, you could bring on very, very advanced and early heart failure. So again, cardio-oncology working together to measure very, very carefully the patient's cardiac function so that they can either withdraw or tone down or break the chemotherapy before reinitiation, perhaps of a different chemotherapy drug. So that's patient A. So you can see how the healthcare scientists have just been littered throughout that poor patient's pathway, but we're glad to know they made a full recovery. So patient B, it's a patient who goes to A&E at the Royal London this time. History of severe leg pain. They've got a swollen and tender right leg as well. Suspected DVT, so they may pop up to, they're otherwise well. So they go from A&E up to the wards, at which point they go down to is it the first floor at the Royal London where you do vascular scan? So have a look at the leg. But while they're having that scan, they develop chest pain. Okay, so suddenly they've got really bad chest pain whilst they're on the table. Another healthcare scientist comes in and does a ECG, and is the abnormalities on that ECG prompt a transthoracic echocardiogram, which shows the sort of subtle signs of a large pulmonary embolism. Unfortunately, that patient then decompensates and heads to the unit, to ITU, where they can initiate thrombolysis or whatever treatment is deemed appropriate for that patient. And then, of course, ITU again, all the care from the critical care scientists, and probably continued intermittent scanning with regards to cardiac function from a cardiac scientist as well. Now I'm biased, so I'm put patient C for cardiac scientist. So this is the chap who's come in with an anterior ST elevation myocardial infarction, brought by London Ambulance Service via the Heart Attack Centre service. So that's just, they go up to the third floor here from the square, assessed in the triage room. There'll be a cardiac scientist there with an echo probe. Yeah, that doesn't look very good. Diagnose the ECG and the echo show the same thing, which is that they've had having a heart attack down the front of the artery that runs down the front of the heart. 2 minutes. Yeah, no worries. I'm almost there. So the bedside transthoracic says get this chap to the lab very, very quickly. They go on and have an urgent angiogram where a little wire goes up through a tube in the wrist, round to the heart, and they put a balloon in and remove the clot and push that into the walls of the artery. So PCI is percutaneous coronary intervention. So they have a stent put in. So there'll be a cardiac scientist in the room, hemodynamic monitoring, looking at rhythm. Like I said before, chest compressions if it all goes a little unexpected. And then of course that patient, before they get discharged, they'll be in overnight. One would assume after a big heart attack. They'll then have an echocardiogram the next day to check their cardiac function and help to risk stratify them. So after 6 weeks, if you've had a big anterior, you're going to have reduced cardiac function. So this chap unfortunately had a severely impaired left ventricle, even on 6 weeks of optimized medical therapy, and in that event was deemed suitable for meeting criteria for a primary prevention ICD. So and there'll be a physiologist or cardiac scientist there programming that ICD, and that patient is now in the system. They're going to have continued cardiac follow-up with, probably yearly clinic appointments, minimal yearly ICD follow-ups, yeah, so they're in the system, and you can see again how cardiac scientists were there at every step of the way for that patient's pathway. So very briefly, in summary, I've given you a really quick overview of the physiological sciences to the best of my abilities, pathways they influence, and then looked at case studies. Perfect.